You may have seen pictures of people living with lymphedema following breast cancer. Heavy, swollen, and painful limbs can be a common side effect of cancer treatments. When lymphedema reaches this critical stage, options have been limited. Until now. Good morning. It is Monday, October 24th. I'm Jessica Lovell. Welcome to the Morning Medical Update. We are live here inside the Dolph C. Simons Jr. Family Broadcast Studio. Our topic today affects 40% of breast cancer patients. So we know a lot of you will have questions. Get those sent in through the links right here on your screen, or you can place them in the chat thread below. We'll get to those in just a bit. Lymphedema is a common side effect of cancer treatments, especially when treatment involves surgical intervention to remove lymph nodes. Radiation and chemotherapy can also be triggers. Early detection and intervention like this screening help in preventing and oftentimes reversing lymphedema. Prevention and conservative therapy are the goals for treating lymphedema, but when the swelling reaches an advanced or critical stage, surgery is an option, but only here at the health system in our region. Why? We're going to find out. Our experts today are Dr. Lindsay Kilgore, a breast surgical oncologist here at the health system. Good morning.
Good morning.
Also joining us virtually is Dr. Eric Lai, a microvascular plastic surgeon. Dr. Kilgore is the physician in charge of the lymphedema program here at the University of Kansas Cancer Center, and is heavily involved in lymphedema research. So we're going to talk a little bit about that. She was published on research several years ago and has some ongoing research, which we are going to hear about this morning. Also with us is Melanie Beck, who came to the Cancer Center for a second opinion. You were diagnosed with breast cancer. You are now in the middle of treatment, Melanie, but the cancer is essentially gone. Is that true?
Yes, thank God.
Thank God, absolutely. Melanie, you mentioned that your passion is your family and also dentistry because that is your profession. You were concerned that if you developed lymphedema, that it would affect your ability to care for your dental patients. Tell us about that.
Yeah, when I came to see Dr. Kilgore, I was obviously scared for my life, but my life involves my family and my job. And what I wanted to know was, after I was done with this surgery, was I still going to be able to continue to care for my patients? So I'm sure she'll tell you what she told me.
What was it like when you met her? What was she going through, and how did you, what kind of options did you present to Melanie?
Yeah, you know, a lot of our patients, when they come in, they're just obviously overwhelmed by the cancer diagnosis and wanting to make sure it's treated, but they worry about the long-term effects after their cancer treatments, and I know that was the biggest concern for Melanie, about if she developed lymphedema. And so here at KU, when we do have more advanced disease and we have to do that big lymph node surgery, we're able to offer something to help to try to prevent it. And so by offering Melanie that hope, and that we could try to do something to hopefully improve her quality of life following cancer treatments, I hoped that it was really going to help her along this journey, to know that we were her team and we were going to do everything we could to help her.
So Melanie, what kind of breast cancer did you have? What was that diagnosis like?
Yeah, I have HER2 positive and progesterone and estrogen positive breast cancer. It was stage 3, class B, or I think that's the way you say it. So it's pretty advanced. And when I met with Dr. Kilgore, she explained to me, well, first I met with my oncologist, did 6 rounds of chemotherapy. After the 6 rounds of chemotherapy, I was a candidate for a double mastectomy with, they call it a radical mastectomy on your left-hand side, where they take, I think she ended up taking 33 of my lymph nodes. When she explained to me what that would mean, was that I had about a 30 to 40% chance of developing swelling in my arm when I was finished with the surgery. And, you know, every day I talk to patients about being proactive versus reactive. And when Dr. Kilgore told me that there was a chance for me to be proactive and have a procedure done that could take my chances from, I think, 40% down to single digits, I was like, sign me up. You know, kind of a practice what you preach type of a situation for me, where I'd definitely rather be proactive than reactive.
Well, yeah, we talk about that a lot, is that, you know, when you when you come to the table quickly and start getting those, your options change the quicker you find the cancer. And in this case, Melanie, you did not get lymphedema. You had the surgery to avoid it. What was that procedure? Tell us about the exact procedure.
Right. So the procedure is called immediate lymphovenous reconstruction or lymphovenous bypass, also called LYMPHA. This is a procedure that we do in combination with our plastic surgeons like Dr. Lai, who we are so fortunate to have as part of our cancer team. And so when I do the axillary lymph node dissection, meaning removing all the lymph nodes under the armpit, so for Melanie, because she had cancer already spreading to her lymph nodes, she needed this bigger lymph node surgery. And so when we remove all the lymph nodes, we team with our microvascular fellowship-trained plastic surgeons here at KU, and they are able to reconnect those vessels. So I'm able to map out which lymph nodes drain the arm to hopefully avoid those, and then they're able to save them and reconnect them to hopefully try to prevent lymphedema from happening in the future.
And this made it easy for me to understand, Dr. Lai. I want to bring you in here because Melanie received this bypass for lymphedema, which kind of makes us understand it. It's like, anytime, we talk about it like jumping off a highway and going around the problem, go around the city, and then drain it out to the other parts of the body, correct? That's what we're talking about, Dr. Lai. So talk about some of the benefits and the risks. What would need to be considered patient to patient?
So certainly immediate lymphatic reconstruction benefits those who know that they're going to get a planned who know that they're going to need to remove a fair number of their lymph nodes. And like you were saying, by providing a bypass, kind of working around the roadblock and getting plugged into a nearby blood vessel, we're hoping to avoid a buildup of traffic or a buildup of lymph in this case that would result in the and result in lymphedema or that sort of swollen upper extremity. So during the surgery, after Dr. Kilgore, for example, has identified and mapped out the lymphatic channel, we're able to go right after them, use a microscope to sort of identify a nearby tiny blood vessel. We're talking around about 1 millimeter in width, sometimes as much as 2 millimeters if we're lucky, and then hand sew those together. So that creates our bypass, sort of offloading them.
So how successful was it for Melanie? The fact that she did not develop lymphedema, does that mean it was a full-on success, or is this something that needs to continue to be monitored?
So we continue to monitor it. We have a very comprehensive program here at KU where we continue to monitor our patients long-term to make sure that she doesn't develop it, or if she does start to show signs, we intervene early. But Melanie's surgery was very successful. We had multiple bypasses that we were able to perform, and so hopefully her risk is extremely low. We're very fortunate here to be able to offer this type of operation where no one else in the region is, and to be able to bring it to our patients.
Dr. Lai, if someone already has lymphedema, maybe an advanced case of it, are there surgery options for them?
Yes, there certainly are different surgeries tailored to different stages of where you are in lymphedema. If you're in earlier stages, certainly, or if you don't have lymphedema, but you're planning on having an axillary dissection or a significant number of those lymph nodes removed, we would consider first with an immediate lymphatic reconstruction. If you've already had a dissection already, or if you've had a number of lymph nodes, multiple numbers of lymph nodes removed, we could consider doing a lymphovenous bypass. This would probably be done more in the extremity of your arm to locate a vein right before your blockage. Even more advanced, we can harvest lymph nodes from somewhere else on your body and, for lack of a better word, almost literally transplant them into an area in order to help recreate those channels. Now, for some people who have really profound lymphedema, who've had this for a number of years, or it's chronic and they've got an enlarged limb and so forth, we may offer some other debulking techniques like using our power-assisted liposuction to help them with their quality of life.
So are all breast cancers connected to lymphedema, or are there just certain types of breast cancer that would make you more susceptible to getting that, just like in Melanie's case?
Yeah, so any patient with a diagnosis of breast cancer that undergoes treatments is at risk for the development of lymphedema, especially when they get lymph nodes sampled, but especially when they get all of their lymph nodes removed like Melanie had. We know that the more lymph nodes we remove, the greater the risk of lymphedema. Some literature quotes up to 40 to 60% chance of lymphedema after an axillary lymph node dissection, which is what Melanie had.
Dr. Kilgore, let's talk research. This is something that you are deep into. You've been published. What are you learning about this condition?
Yeah, so our research here at KU really focused on early intervention and prevention of lymphedema, because we know that when you get to the chronic lymphedema stages, it's really hard to reverse. And so we presented on that early detection truly is key. And so we have special technology here at KU Cancer Center where we can detect it at the subclinical level, meaning before patients develop that swelling. And we can actually intervene early, teaching them home-directed measures like self-massage, compression, and things, and actually reverse the lymphedema. So prevent it from becoming that chronic, painful stage that some women get to. And we've really developed a comprehensive program here with lymphedema nurses, lymphedema therapists, and so it really is a team approach. And in women who don't get on our program early, we do have the later surgeries, like Dr. Lai mentioned, that our plastic surgeons can offer them as well.
So you presented to your peers at the American Society of Breast Surgeons before, and you're hoping to go back. But can you tell us what this research and results will ultimately mean for patients?
It really means that we can offer them hope. Hope that they're not going to have this debilitating disease and side effect of their cancer treatment as a constant reminder of everything that they went through. So we're really hoping to establish a protocol for women all across the country, even not just here at KU, on when we monitor, when we intervene, and our methods in prevention and treatment.
If you have any questions or want more information, I want to go ahead and put a QR code up on our screen today. Dr. Lai, just what questions do you get? What questions should people be thinking about? And what kind of information can we offer them if they're searching for answers?
So a lot of questions. A lot of questions that people answer are, am I an appropriate candidate? And also what sort of surgery would be offered to me? How long are the surgeries? Like, a lot of people are concerned, like, are these like similar to like sort of like other flap surgeries they may have heard about in relationship to their breast reconstruction? In general, though, I mean, we have, a wide range of options offered, for people at various stages of their lymphedema. These surgeries generally don't entail, are not as long as or as invasive as some of our reconstructive surgeries. And some of them even allow you to go home the same day.
I want to take a quick moment to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, to check our COVID count, see how we did over the weekend. Good morning. Happy Monday.
Yeah, happy Monday. It's still nice out, too.
I know, right?
Yeah, so far the cases at the health system kind of went up over the weekend. We're still trying to get some information on that. But 28 active infections. 5 in the ICU, 2 on the ventilator, still 20 in that recovery period as well. So unfortunately jumped up a little bit. It may just be due to some clerical things. We do take off the active infections moniker after a certain number of days here. So we'll go ahead and look into that as well. But it's unfortunate that we've kind of jumped up after being down in those high teens.
Okay, what your thoughts on this? Researchers found people who wore a mask in public behaved more ethically in public than those who don't. So walk us through what those results ethically can mean lots of different things, but talk to us what these mean to you.
Yeah, and again, I think this research was conducted in China, so again, there is a significant cultural difference in China than it is here in the United States. But there was always, I think it is based on the premise and the fear that when you are wearing masks, people are more prone to do things. We know there certainly is that image of the bank robber coming in with the mask. We know that was a concern early on with some of our minority neighbors and populations having that concern as well. But what this research showed here was that was not the case, that they, again, ethically as well. Remember the cultural differences in China, but people were being more conscientious about what they were doing day to day. I think some of that also has to do with the social distancing, things like that, but they did not see that people were being more violent, causing more crimes, doing anything like that. They were, not only thinking about themselves, but thinking about those people around them as well. So.
All right, here's another one. Boston University is defending its research after a report studying the COVID-19 Omicron variant's lower severe infection rate was met with criticism among news outlets and one of its financial backers. Walk us through that one.
Yeah, I don't think they should have to defend it necessarily. This was a headline that was taken totally out of context, which we have seen throughout the pandemic. There was experiments going on with SARS-CoV-2. It was in a lab. It was with mice. What they did was they took the Omicron spike and put it onto the original Wuhan isolate or the Washington isolate to look to see about infection and entry into the cells. Basically, they were asking the question, does the spike alter the severity of the virus? That was the question being asked. And what they did was they looked at Omicron. They looked at the Omicron spike put onto that original Wuhan isolate virus. And then they looked at that original Wuhan isolate virus. And I think what caught the headlines is they said that there was 80% mortality in those mice that had the Omicron spike on the original Wuhan isolate. So that took the headlines. A lot of people were up in arms about that. But what you also have to understand is that 100% mortality, all of the mice died in that original Wuhan isolate as well. And so the other thing to remember is this is mice. It's not the best model that we have for studying it, but it is one of the models that we have. So it's not always true to human infections either. But I think this was just a matter of a headline or a certain line or result in the paper being misconstrued in the media. And we know that there has been so much uproar about things like gain of function research, as well as the virus was a lab leak spill coming out of the Wuhan Institute of Virology. There's absolutely no data to support that. So there's just a lot of things that have kind of conspired or come together to help this promote this last headline and everybody being up in arms. But overall, what the conclusion of that research was that the spike protein did not really have an effect on the severity of disease, and there were probably other genes within that virus that had an effect on severity of disease. And I think that's the message we need to take away. And that is one of the things we have talked about on here as well. It's not all about spike. There are other proteins and genes within that virus that can cause severity and different functions within our body.
This is why we need you, so we understand exactly what these studies mean, because we know people read headlines. So we need to go beyond the headline and really, really dig in. So thank you for that. Any reporters on the line today? Okay, so let's get to our community questions. I've got one for Melanie. Susan wants to know, Melanie, how long did it take you to recover from that surgery?
Yeah, I'm about a month out right now. I'm feeling way better, much more like myself. Maybe not back to 100%, but I would, so the right side, I just had a regular mastectomy, I guess an average mastectomy, and that felt great. The left side, where they did a more extensive surgery, I kind of treated like a hurt wing for a very long time. They actually send you home in a sling. They don't want you to raise your arm over your shoulder over 90 degrees. And I'm an overachiever, so instead of not raising it over 90 degrees, I kind of carried it around like it was a hurt wing, like I said, for a long time. I wish I would have used my arm more. I think if I would have stayed within the bounds of what they asked, but also moved it around a bit more, I think I would have recovered even faster. So I would say right now, at a month out, I'm feeling great. I think I'll feel even better in a couple of weeks. So.
And you're still going through treatment. Tell us about that.
Yeah, so because I'm HER2 positive, I'm a candidate for immunotherapy. The way they describe it to you is my cancer has a little flag on it that says, "Hi, I'm cancer." And so they have targeted medications or targeted chemotherapy medications that can just treat that. So I have 12 more rounds of that that I'll do over the next 6 months. And then I start radiation at the beginning of November. So I'm through the worst of it, and very thankful to be through the worst of it and feeling like I'm getting back to being myself. So
you look great. You sound great, and we're glad you're doing well. Jean wants to know, how does the power-assisted liposuction work on long-term swelling? Which one of my docs was talking about that one? Dr. Lai? Tell us about that.
So certainly when our tissues get really swollen with lymphatic fluid and so forth, it can get really fibrous. Sometimes, the procedure can be to directly excise, but if we're trying to remove or debulk a lot of that heavy swollen tissue, across like, a swollen limb, we'll use a power-assisted liposuction, not only for like, the surgeon's ease as well, but just to help us like remove some of that more like difficult fibrous tissue. And that just means that the tip is sort of like, wiggling back and forth the liposuction tube, if you can imagine, as the suction is being applied. But it's just a more efficient way of allowing us to remove what can be sometimes some stubborn tissue to remove.
Juan wants to know, are there international protocols in prevention of lymphedema post-chemotherapy? Do we know anything about that?
Yeah, so it's being studied all over the country right now, and that's why we really are on the forefront here at KU. We're the first to publish more about prevention. There are some international studies, but no one in the United States has published the type of data that we have or has the comprehensive database to support the things that we are suggesting. And so it's really exciting to be on the forefront of all of this and hopefully present our new research soon. Yes. So that we can continue to pave the way in lymphedema treatment and prevention.
Dr. Lai, can exercise aggravate lymphedema?
No, certainly. I mean, certainly immediately after your surgery, we ask people to kind of like take it a little easy, but that's not because we don't want them to exercise ever again in the rest of their life. We just merely don't want people to tear a suture or something like that. But definitely, like, after you're out of like, let's say like, 4 to 6 weeks after your surgery, after you've talked with your physician or your surgeon, yes, we would like you to go back to doing all the things that you did beforehand, which includes, getting up, moving around, and also exercise.
Chris wants to know, what if I'm allergic to dye? How do you map it out?
We have different types of dyes that we use, and we use different colored dyes or endofluorescent green dyes, and so we have different options depending upon the type of dye that you're allergic to. Most people are allergic to a specific type of dye, and so we have alternatives for that. And we also have medications that we can give in case you do have an allergy to try to avoid you getting that allergy prior to us injecting any of the dyes.
Angie wants to know, Melanie, how did you find your breast cancer? Were you doing regular screenings?
I have a bit of an unfortunate story where I found my breast cancer very early on. I have a 3-year-old, and when I finished breastfeeding, I was just doing a self-exam at home and found it. I'm fairly young. I'm 34, and I found it about almost 2 years ago now. Because I was just finishing with breastfeeding, there's a lot of changes in the breast tissue right after breastfeeding, and so I was advised by my physicians. I had a scan, they found a cyst, it was kind of a red herring. Things continued to change. I sought another opinion who said it was just fibrous, dense breast tissue, and it wasn't until I got to KU that they really took me through a protocol of scans and biopsies that really found the breast cancer. Unfortunately, like I said, it was pretty advanced by the time I was able to start treatment. But I'll tell you that what I really appreciate about KU, now full disclosure, I am a Jayhawk myself, so I'm a bit, biased. But that being said, I love that they have a specific protocol they take you through. This is step 1, step 2, step 3, and I feel like that keeps things from falling through the cracks. And maybe if I had sought treatment from KU first, then, hey, I wouldn't be on this show right now because I wouldn't have had to have all my lymph nodes removed. So.
Well, Melanie, we just came off of a week last week of all second opinions, the power of second opinions. And I love that we're just going to continue this on into this week because that's so important. Just seeking the second opinion is why she's here. But it's interesting. Is her story rare? Because she's saying she caught it early. Why would it be so aggressive if you catch it so early?
So Melanie found it kind of earlier on, and this is common. We don't want to ignore breast masses in women. Even though you're young, it still should be properly evaluated, and that's what Melanie's talking about is with all of our imaging and protocols. Just because you're young, it still could be a cancer. And so because she found it a while ago, by the time she had come here, it was in a more advanced spread and had already gone to her lymph nodes, hence why she needed the lymph node surgery. But we're just glad to take care of anyone whenever they come here, and we're always available for those second opinions so that we can offer you our thoughts and make sure that the workup that you've gotten elsewhere is the appropriate treatment.
Kenneth wants to know, does this work for lymphedema caused by other cancers? He says, I had melanoma skin cancer and now suffer with lymphedema in my lower extremities. So is that something that happens, or could that have been caused by something else?
So you can get lymphedema in your upper extremities and your lower extremities depending upon where your cancer operations are. Obviously, I'm a breast cancer surgeon, and so mine are mainly the upper extremities. But I'll defer to Dr. Lai on the treatments for lower extremity lymphedema, but we see this very commonly. And as I'm in charge of the lymphedema program here, we're really working on prevention for lower extremity lymphedema as well, as this is a new concept that I'm continuing to grow. And so we'll be working on prevention, but currently Dr. Lai and Dr. Butterworth and our other microvascular fellowship trained plastic surgeons do have treatments for the lower extremities. Dr. Lai?
Exactly. I mean, certainly people who have been treated for like melanoma or other aggressive cancers in their lower extremity can also have their lymph nodes removed from like their groin region, kind of like in a similar fashion to how women with breast cancer have their lymph nodes removed from their armpit area. And so by that same extension, people can develop lymphedema in their lower extremities. The same techniques that we would use, an immediate lymphatic reconstruction, a lymphovenous bypass, a vascularized lymph node transfer, all of those procedures, those can be applied to patients with lower extremity lymphedema. In addition to using debulking procedures like we talked about, to remove if we have chronic lymphedema, to remove sort of that heavy boggy tissue, in that case we would use liposuction.
And last question, Dr. Lai, for you. You mentioned it earlier about who makes a good candidate, but just go over that again. Marley's curious. Who would make a good candidate for this specific procedure?
So certainly, I mean, I think like any woman who's had lymph nodes removed from their armpit, or their breast surgeon is considering to remove a fair number of lymph nodes from their armpit, certainly at least would deserve a consultation, with one of our microvascular plastic surgeons to discuss, what is appropriate in their situation. Women who have already had their lymph nodes removed and are wearing a compression sleeve, and they're noticing they're not getting resolution of their symptoms, or they're having progression of their symptoms. Those are also people who are, who I think are who make good candidates at least for initial consultation, then determining, what surgeries, if necessary, are needed.
And then last question is from John. When does lymphedema go away?
Yeah, so we really try here at KU to intervene early before it becomes that chronic progressive lymphedema, and that's why the early detection is key. Because if you can find it in the subclinical or early clinical levels, that's when it's reversible from what our data is showing. But when you get the more chronic lymphedema, it's more treating the symptoms. And so doing that liposuction and doing the treatments that Dr. Lai is suggesting is for more of the chronic. And so that's why we really focus on the prevention or the early intervention with the surgery that Melanie had to prevent her from getting lymphedema by doing the bypass before the lymphedema develops.
Goes back to expanding those options. The more you can get tested and screened and get to it early. Last question is from Jo Ellen. Good morning to you. She wants to know if we can get a sneak peek of what Dr. Stites is going to be talking about on Wednesday. And yes, we can. Jo Ellen, KU Med Center got a big grant to help study obesity. So we're going to have the researchers on that are involved in that study. And we're also going to have some patients that will benefit from that study. So stay tuned for that. Again, we've put the QR code up on your screen. If you need more information, would like more information about our lymphedema program, please hover over that, click on it, find more information, find Dr. Lai, Dr. Kilgore, and we will get your questions answered and get you seen. I want to get to our final thoughts, though, from our guest. Dr. Kilgore, start with you.
Yeah, so I really think that KU has the most amazing comprehensive cancer program. And with our recent NCI designation for being comprehensive in our cancer care, we can offer you all everything that you would need. It really is a team approach to treating our cancer patients, not just breast cancer patients. And it starts with, imaging and our radiologists who are all fellowship trained in the areas that they do. Fellowship trained pathologists who specialize in your type of cancer. And then the surgeons, as you heard Dr. Lai and I speak, we really are focused in what we do. I do breast cancer only, and Dr. Lai does, breast reconstruction and lymphovenous surgery. And so we really, as a team, come together and specialize in your specific type of cancer so that you can get the best possible outcomes by coming to NCI Comprehensive Cancer Center.
Thank you, Dr. Kilgore. Dr. Lai, your final thoughts today.
Yes, the University of Kansas is the only NCI designated cancer center in the region. So we have the means and the appropriate staff to help you look out for your lymphedema, manage your lymphedema. But if it becomes necessary, have surgery to help, like reduce or improve your quality of life with your lymphedema.
Melanie, thank you so much for being with us today and sharing your story, and really just kind of being the face of what it means to detect and to do self-exams and to get in and to seek the second opinions and to really open up your options for treatment. What are your final thoughts today? What should we head out into the week knowing?
Well, I think that Dr. Kilgore really summed it up, that KU has been second to none for me. It just really hit home when she said that the radiologists that were doing my initial screening only look at breast tissue, which was not the experience that I'd had prior. And that was how they were able to detect, even though I was very young, that this was not something that was normal, but it was actually cancerous, as opposed to the other radiologists that had looked at it in the past. And just from that moment on, my experience with KU has been second to none. I wouldn't go anywhere else. I considered traveling across the United States to seek treatment at MD Anderson, but once I met with the team here at KU, I was confident that they would be able to save my life, and they've done just that. So I'm very, very lucky.
Thank you so much for being with us today, Melanie. Dr. Hawkinson, your final thoughts today.
Again, I think it's important. We've seen the importance of seeking those second opinions and getting these cancer centers, these comprehensive cancer centers. Just again, always grateful for working with my colleagues here, and we're all working for the same goal.
Thank you so much, Doc Hawk. Thank you for being with us today. You've had some great questions. And again, if you want to seek out more information, click on that QR code. More information about our lymphedema program. They will answer all of your questions right there. Everyone, go out, make it a great day. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update, the family of a child born with health problems finds out she needs brain surgery at the age of 2.
Colby has a tumor that kind of looks like a barbell.
Her recovery, a team effort between the health system and Children's Mercy Hospital. We'll take a look at the surgery and how Colby is doing now. That's Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.